Hey everyone, you are welcome to Medical Sciences Made Easy by Naphtali Muhumuza. And in this session, we want to discuss cardiac function tests. And these cardiac function tests are requested by doctors, by clinicians, to confirm the onset of any heart problem, especially myocardial infarction, angina pectoris, and sometimes coronary heart diseases. So we want to look at how we can diagnose these diseases. And using different laboratory tests measuring the cardiac markers. And these cardiac markers, their major significance, the significance of doing these tests is to diagnose. You are responsible for diagnosis of acute myocardial infarction. And this acute myocardial, we are calling it myocardial infarction. And this myocardial infarction, sometimes we can call it cardiac necrosis, because it is always due to the blockage of the blood supply, and especially oxygenated blood. We see the cardiac muscles being supplied by the arteries that bring in oxygenated blood to the muscles. So whenever there is blockage of the supply, we see the cardiac tissues being deprived of oxygen, which results into ischemia, and ischemia can lead to tissue necrosis, which we are calling myocardial infarction, and sometimes we used to call it heart attack. You can call it heart attack. So we can use the cardiac markers to diagnose that. And also we can use them for prognosis. Prognosis means monitoring people who are on treatment. Here you are monitoring people or patients, to monitor patients on treatment. So we can always use cardiac markers. And sometimes we can use also cardiac markers to rule out angina pectoris, causes of like angina pectoris, coronary insufficiency, and heart failure, and heart failure. So these are some of the significances of performing different cardiac markers, and different cardiac markers include the cardiac markers we are talking about, or what we call the cardiac function tests, include what we are going to discuss in this session. They are categorized into two, whereby we have enzymes and others are just proteins, though even enzymes are also proteins in nature. Excuse me. So these enzymes which we use to monitor cardiac include creatine kinase, or sometimes we call it creatine phosphokinase. Then it includes lactate dehydrogenase. Then another enzyme we can see is aspartate aminotransferase. This one, we can also call it, in abbreviations, we can call it CK, or sometimes we can call it CPK, meaning creatine phosphokinase. Then LDH, that is lactate dehydrogenase, and AST is called aspartate aminotransferase, or formerly we used to call it SGOT. You can even call it serum glutamate oxaloacetate transaminase. So these are the enzymes among the cardiac markers. Then the proteins include, majorly we see myoglobin, and troponin. So these two are the major proteins that we are seeing or we monitor in cardiac markers, whereas the enzymes, there are three. We have creatine kinase, lactate dehydrogenase, and aspartate aminotransferase. So we are going to begin with enzymes. In our discussion, we are going to begin with enzymes, then we shall end with the proteins. So enzymes which we are going to discuss, number one, we are going to begin with CK. Going to begin with creatine kinase, or we have said we can call it CPK, creatine phosphokinase, which is a cardiac marker. And this cardiac marker is found in the muscles, both skeletal muscles and cardiac muscles, and sometimes in the brain, whereby it has different isoenzymes. And the isoenzymes, what are isoenzymes? Isoenzymes are different forms of the same enzyme. One enzyme having or existing in different forms depending on the tissue where it is found. So we shall see that CK has different isoenzyme, that is CKBB, has CKMB and CKMM, whereby this one is for the brain, specific to the brain tissue, this is specific to the cardiac, and this is specific to skeletal muscle. So among the three, and sometimes this CKBB you can call it CK1, this one you can call it CK2, this one you can call it CK3. That is its other name. And we are seeing CK1 is for the brain, is found specifically in the brain. CK2, which is MB, is specific to cardiac. So whenever we are looking at cardiac markers, we are interested in MB. Apart from doing total CK, we can always do isoenzyme CKMB to confirm the origin if it is the heart. That is by doing creatine kinase MB. And after performing this enzyme, we shall see it is more, especially CKMB, it is more sensitive and specific to cardiac. So whenever there is a problem with the cardiac, maybe you have got an abrupt chest pain, maybe due to onset of myocardial infarction, we see the most sensitive marker and more specific is creatine MB, creatine kinase MB. And this CKMB being more specific and sensitive, we see it begins to rise 4 to 6 hours. It attains peak or maximum between 24 to 48 hours after the onset of chest pain or myocardial infarction, and returns to normal within 2 to 3 days. So we are seeing creatine or total creatinine, it starts to rise whenever we see chest pain. You count 4 hours, that's when it begins to rise in serum. Then by 24 hours to 48, it attains the peak. Then within 2 to 3 days, it returns to normal. That is what we are seeing on illustration in the graph, that whenever we have total CK, creatine kinase, we see it beginning to rise at the 4th hour, attaining maximum at 24th hour, then returns to normal within 3 days. This is total creatine kinase. So that is how it rises. So whenever you are in the laboratory or you are a doctor, you want to request for this test, always consider the onset when the chest pain appeared. That's why we are seeing here, this is the onset of the chest pain, and this is the plasma concentration of the enzyme. So it begins to rise after 4 hours. So whenever someone has a heart attack and it begins, maybe it has occurred within 1 hour, and you're requesting for creatine kinase, it might not be so important because it is not yet high. So that is what we can discuss about creatine kinase. And another enzyme we can talk about apart from creatine kinase, after seeing its isoenzymes and where they are found, seeing that CKMB among all the isoenzymes, it is more sensitive and specific to cardiac, and we have seen it rises between 4 to 6 hours, reaches maximum between 24 hours to 48, and returns to normal within 3 days. Another enzyme we can look at is LDH, and this LDH is the second one, which we are calling lactate dehydrogenase. Lactate dehydrogenase is an enzyme which is non-specific. It is non-specific. Why is it non-specific? It is almost found in all tissues in the body. That is lactate dehydrogenase. And we see this lactate dehydrogenase catalyzing the reaction by oxidizing lactate to pyruvate in the presence of LDH, whereby it utilizes NAD, producing NADH. So this is what it does. And we are saying it is found in different tissues, whereby this LDH has different isoenzymes. And among the isoenzymes of LDH, which I can zoom this side, this LDH has different isoenzymes. That is 5 of them, whereby it has LDH 1, it has LDH 2, then it has LDH 3, then 4 and 5. These are different isoenzymes of LDH, whereby LDH1 is specific to cardiac, is the one found in cardiac muscles. LDH2 is found in the membrane of red cells. Then LDH3 is found in many tissues like lungs, kidney, pancreas. We can find there LDH3, whereas LDH4 is found in skeletal muscles, and to smaller extent the liver. Whereas LDH5 is majorly found in the liver cells, that is hepatocyte, and to smaller extent skeletal muscles. So these are the different isoenzymes. That's why we are saying it is non-specific, because it is found in different tissues. And we can always perform protein electrophoresis to separate these different isoenzymes of LDH, because they migrate differently according to the size and net charge. So we are seeing whenever we are interested in a cardiac marker of lactate dehydrogenase, it is always advisable to do LDH isoenzyme 1. And this LDH isoenzyme 1, being cardiac specific, it is the one that is elevated in myocardial infarction. And sometimes we are forced to do that when we have LDH1 isoenzyme high, we are suspecting acute myocardial infarction. And after suspecting it, sometimes we are required to perform LDH2, because sometimes it is also smaller extent produced in the cardiac. So whenever we do the ratio, we find LDH isoenzyme 1 is greater than LDH isoenzyme 2, and we do what we call LDH 1 to LDH 2 ratio, and we find is greater than 1, and this one LDH means LDH1 is greater than LDH2. This one confirms acute myocardial infarction, or maybe which has led to heart failure, or maybe angina. So that is how we can confirm using LDH1, but LDH1 remains cardiac specific. So whenever you are looking for a specific marker for cardiac, please look for LDH isoenzyme 1 is the one which is specific for cardiac. And after looking at this LDH, we can also look at the last enzyme, which is a marker under cardiac, and this enzyme is known as AST. And AST, which is the third one, we said AST is known as aspartate aminotransferase, which is also non-specific to cardiac because it is also found distributed in the cardiac. It is in the cardiac, it is found in the liver, it is found in the skeletal muscles. So we see different conditions that affect cardiac, that affect the liver, that affect the skeletal muscles, that affect red cells. Even red cells can increase AST levels. So whenever you find aspartate aminotransferase, which we looked at under liver function tests, we can also suspect, apart from myocardial infarction, we can suspect acute myocardial infarction. We can suspect hepatocellular damage because it's also found in the tissue. So we can find it in hepatocellular damage. We find it in skeletal muscle dystrophy. We find it in hemolysis or in hemolytic anemias. So that's why we say it is non-cardiac specific. So whenever we find AST and we assay it in the serum and we find it is elevated, before we confirm acute myocardial infarction, we are required to also perform other guys to confirm, like LDH isoenzyme 1. We are required to perform CKMB, which can confirm that the AST being high, it is an origin of heart attack or myocardial infarction. Because these guys, for them, they are specific and sensitive to myocardial infarction. So whenever we find a rise in AST, we are required to confirm its origin by also performing LDH1 and LDH and the CKMB to confirm the origin. And as we saw also that this LDH being distributed in many tissues, we see different conditions also affected. That is acute myocardial infarction if it is LDH1. We see hemolysis or any hemolytic anemias, increasing LDH. Then we see any problem with the lung like pulmonary embolism affecting the LDH. Any tumor or any inflammation causes rise in LDH. Kidney failure, we see it there, or kidney necrosis. Pancreatitis, we see it elevated. Skeletal muscle dystrophy like rhabdomyolysis, we find it elevated. Liver cancers, we find it elevated, and the hepatocellular damage, we find it. So it is distributed in many parts, which is the same as AST. So whenever we find these ones high, we are required to do specific isoenzymes to confirm their origin of elevation. Whereby that's why we are saying we are required to do LDH1 and CKMB, which are specific. So among the enzymes, the three enzymes, the one which are specific to cardiac, don't forget that it is LDH isoenzyme 1 and CK isoenzyme MB. They are the one that are most sensitive and specific to myocardial infarction and causes of heart failure. So this is what we can discuss about the enzymes, the three of them. Then the last one we can talk about is the proteins, which we introduced. And these proteins, we have number one as myoglobin. And this myoglobin, myo means muscles. So it is found in myocytes and it is found in both cardiac muscles and skeletal, meaning it is non-specific to cardiac. It's non-specific, so it can be elevated in in damage or trauma of the skeletal muscles, even trauma of the cardiac. So making it non-specific to the cardiac injuries. And this myoglobin is the one that is responsible for storage of oxygen and supply of oxygen in the muscles. As we see hemoglobin in the blood, in the muscles, it is not hemoglobin but myoglobin. So it is the one that makes sure oxygen is supplied in all muscle. And this myoglobin is the earliest. It is not, this one you can write it as a note. It is the earliest cardiac marker to rise. It is the earliest marker to rise after onset of heart attack, after onset of myocardial infarction. It is the earliest, whereby for it begins to rise between 2 to 4 hours. It attains the peak or maximum between 12 to 24 hours and returns to normal after 2 days. After 2 to 3 days, sometimes it can go to 3 days, but majorly 2 days, it returns to normal. So that's why we see this myoglobin. When we see on the graph, we are seeing within 2 hours it has started to rise. It rises between 3 hours, 2 to 4 hours, it is rising. It is reaching a peak by 12th hour to 24th, and it is returning to normal within 2 days. That is 48 hours. So within 2 days, it returns to normal, which is different from AST and LDH, whereby for LDH, it is the one that takes long to rise. LDH, for it starts to rise between 6 to 8 hours. It attains the peak between 48 to 72 hours and returns to normal after 7 to 14 days. So meaning among all the markers, the one which takes long to return to normal is lactate dehydrogenase. So whenever you get a patient who is telling you that last week I had chest pain and you want to rule out cardiac infarction or myocardial infarction, the best marker you can request is LDH enzyme 1, because for it takes 7 to 14 days to return to normal. And like myoglobin and CKMB, which return to normal between 2 to 3 days. So for the onset which has taken long, you're always required to look for LDH enzyme 1, which takes 7 to 14 days. So this is the graph for the LDH. We see LDH beginning to rise at 8 to 12 hour, and it is reaching a peak between 48 to 72 hours, and then it is returning to normal after 14 days. So it takes longer. But myoglobin, we are saying, is the earliest to rise. So whenever we assay myoglobin using ELISA methods, and we find this myoglobin is high, if it is elevated, it does not guarantee myocardial infarction. So we need to confirm its origin by also performing LDH1 and CKMB to confirm the origin of elevated myoglobin. But a negative myoglobin, when we find myoglobin is normal in the blood, it rules out myocardial infarction. Because we have said it is most sensitive, it is the earliest to rise. That meaning it is more sensitive but non-specific. Sensitive but non-specific. So whenever it is normal, at least we are sure someone has no myocardial infarction. But when it is positive, we are required to do the specific isoenzyme, CKMB and LDH isoenzyme 1, to confirm the origin of elevated myoglobin in blood. That is what we can mention about myoglobin. Don't forget it is the earliest to rise. After the onset of chest pain is the first to rise. That is myoglobin, and it is the first to return to normal followed by CK, total CK. And after expounding on myoglobin, the last one we are remaining with is troponin. This troponin is also a protein found in striated muscles. So the second protein is troponin. We are saying this troponin is a protein that is found in muscles, and it has different isoenzymes. And the isoenzymes of troponin, we have troponin I, we have troponin T, and we have troponin C. These are the different isoenzymes of troponin. And this troponin having different isoenzymes and is found both in cardiac and skeletal, we are going to see isoenzyme I and T are the ones that are cardiac specific, whereas C is skeletal. So we are not, whenever you are only querying heart problems or myocardial infarction or heart failure, we do not expect you to order for troponin C, because for it is specific for skeletal. So the most sensitive one is T and I, but among all, when you don't have the money to do both, then the most sensitive, we are seeing T and I is cardiac specific, but we shall tell you that troponin I is the most sensitive and specific than T. So if I'm interested in myocardial infarction, I prefer doing troponin I than T. Troponin I stands for inhibitory, troponin T stands for tropomyosin, and troponin C stands for calcium, and these guys are involved in muscle contraction during muscle sliding filament theory. And these troponins are determined by ELISA methods, and its range should always be less than 0.4 nanograms per liter. And whenever it goes to 0.5, it becomes 0.5 and above, it becomes positive, and we can suspect myocardial infarction. And the most sensitive and specific is troponin I. So if I can add here among the guys which are specific to cardiac or the specific cardiac markers, I can also add troponin I. Troponin I is also specific. So these are the guys which are specific, more sensitive and specific to cardiac markers. Three of them, that is LDH1, CKMB, and troponin I being cardiac specific. And this troponin, for it also begins, this is the graph, the one in red. It is the graph for the troponin, and we are seeing it is beginning to rise at the 4th hour. Between 4 to 6 hours, it begins to rise. Between 4 to 6 hours, it reaches peak between 12 to 24 hours. As we are seeing on the graph, this troponin is reaching the peak between 12 to 24 hours, and it is returning to normal. It also returns to normal after 7 to 10 days. It returns to normal between 7 to 10 days. So meaning, as we can add on our summary, which we are putting here, this part is for our summary. We are saying, if I can add on my summary, we are going to tell you that LDH is the one that takes longer, is the longest to return to normal. And it is followed by troponin. Troponin follows, because this one we said it takes 7 to 14 days. And this one we are going to say it takes 7 to 10 days. Why am I putting them here is to know that whenever you are suspecting myocardial infarction has taken long after occurring, after the onset of chest pain, that you can easily know which test you can request to perform. So these ones, we saw the ones which these ones take longer to return to normal, and we saw the one which takes shorter time is myoglobin followed by creatine kinase. So the one which takes short time to return to normal is CK, is myoglobin is the first one, which returns to normal within 2 days, followed by total CK, which turns to normal. This is 2 to 3 days. This is in 2 days. So always note, these are very important to note as a medical worker or as a student who are going to sit for exams of cardiac markers. And that is what we can discuss about. So this is the summary I have here. I have extracted from the many words I have spoken ever since we have started this session. And I always remind you to subscribe, share your comments, and like the video for the betterment of our channel. And in summary, I'm going to remind you that among all things we have spoken, remember 3 enzymes or markers that are specific to the cardiac. That is lactate dehydrogenase, isoenzyme 1, creatine kinase, isoenzyme MB, and troponin, isoenzyme I, are the most cardiac specific. And sometimes we can add troponin T, but I is the most. Then we have seen that the duration of onset of chest pain, that LDH takes a longer time to return to normal, followed by troponin, which takes 7 to 10 days. And the ones that take short time to return to normal is myoglobin and CK, whereby in 2 days they can return to normal. And they begin to rise early and return back earlier. And we have seen myoglobin is the earliest, whereas LDH is the longest. Thank you so much for listening. We are always privileged to have you, to teach you or to add or to have an impact in your life. Always like the video as a way of appreciation. Thank you so much.